orthopedic surgeon with a subspecialization in foot and ankle. He's an executive of the Canadian Orthopedic Association and the Canadian Orthopedic Foot and Ankle Association. Please join me in welcoming Dr. Warnick.
So I work in a community hospital. It's 3 different sites. It's one of the largest community hospitals in Ontario, but primarily I have a tertiary care practice community setting. I do teach residents and fellows, but it's not an academic center. And I've been very impressed with all the efforts of everybody giving their talks today. I'm impressed by how many bright people there are who have a lot of energy investing a lot of their time into this particular problem. And we all know that diabetes is a big problem. We know that neuropathy is a big problem, and we know that if people have neuropathic changes, particularly autonomic, motor, and sensory, we should be following them more often. That's one way to prevent ulceration, right? If you're watching them more often, you're teaching them self-care, they're going to get less often than ulcerations. We know that ulcerations lead to a large percentage of amputations, particularly non-traumatic amputations. Okay, so Monday morning, I walk in, this is my clinic. And how in the world I ever got to start doing these kind of things, I have no idea. But in Scarborough, we have a huge, where I work, we have a huge immigrant population. We have a real problem with access to care, like many people do, in terms of accessing resources for these particular patients. We all know about history for the exam. We're not doing polling questions. We all know about looking at diabetic foot ulcerations and classifying them so we can get an idea of what prognostic factors involved with treating these wounds. And we just heard wonderful talks about osteomyelitis, and obviously in recurrent wounds and recalcitrant wounds, we want to be very suspicious about osteomyelitis. And I agree we should get an X-ray, not an MRI. Let's start with an X-ray. It's a $5 test. Often you can see a lot on a $5 test. People wander in my clinic, wander in my office, and they've had an MRI and never had an X-ray. And for an orthopedic surgeon, that's like an them, right? Like she's talking about an X-ray. Okay, so we talked about vascular supply and infection control. People have talked about that beautifully in this room. They're way smarter than me, and like go talk to them about vascular and infection stuff. Pressure offloading. Okay, so that's kind of orthopedic-y, right? And there's also people who are way smarter than me in this room about dressings. So you talk about that. So pressure offloading. Okay, so I see people who have wounds. I debride the wounds, try to create a healing stimulus, pressure reduction, drainage of the pus, all these things. I actually don't like doing that very much because I feel like that's not really like where my time is best spent. My best time is spent talking about mechanically offloading the foot, because we know that people have change in biomechanics and change in pressure need to have their foot offloaded. And it's a very difficult conversation to have with people because they walk into the clinic, they have a plantar ulcer, it's weeping, you send them infectious disease, you send them to the vascular surgeon, they come back and they still have an ulcer that's weeping, and they still have mechanical deformity in their foot. And you say, hey, why don't you stop walking on your foot? And they say, hey, why don't you screw off, because I can't do that. I can't live my life. How am I going to go to work? How am I going to drive my car, right? And you're often, I am often, I don't know, I think probably most of us are often the first people to ever discuss with patients, hey, you have sharp neuroarthropathy, what does that mean? Hey, you might need an amputation, what does that mean? And they often look at you like you have 3 heads because they're like, I just have a hole in my foot. Why can't this hole get better? So having that discussion with them about offloading is critically important, and critically important to actually make them understand that if they don't stop offloading it, they're going to have risk amputation. So I had lots of fun polling questions. There's me like doing all the operation, and the guy on the top is my fellow just standing there doing nothing. Okay, so goals of amputation, pretty obvious, right? Get rid of the infected stuff, get rid of the dead stuff, try and create a wound base and a soft tissue coverage for the foot, right? So my goal is always to create a plan to grade stable foot, right? So I talk a lot, and it's funny that I've given this talk because I don't do that many amputations. I do a lot of limb salvage, particularly for my sharp neuroarthropathic patients. We talk a lot about limb salvage, and a lot of things that happen when you start talking about limb salvage or amputation patients is they say, well, I don't really want my leg cut off. Like, do you have to cut my leg off? I'm not ready to have my leg cut off, right? And so this is like a conversation that is really challenging to have with patients, and sometimes, and we don't talk about this enough, is patients are not mentally ready to have their leg off. And I know who they are because I say, we should have amputation, and they look at me like I'm crazy. And they say, well, I'm not ready to do that. Or they walk in there like, please cut my leg off, right? Like they're ready, right? And they do great because they are mentally ready for that step. So if we're going to look at creating a plan to grade stable foot, we're going to look at how much tissue loss there is. Is that reconstructible for us? We're going to look at the anatomy of reconstruction. So how much bone loss is there? How many joints are affected? How many joints are dislocated? How large is that reconstruction going to be? How sick is this person? what's the vascular status of this patient? I'm going to send in my colleague John Yu, who's excellent at seeing them very quickly for me. And are they sick, right? Do they need to come into the hospital and be on antibiotics and have smart doctors look after them rather than a carpenter? Okay, so Mickey Pinzer. So Mickey is, I don't know for you guys, for me it's like fourth on the left. He's the guy with the glasses, the older guy with the glasses, with the pink shirt. So Mickey's kind of like, I don't know if anybody knows who he is, but he's a really well-known orthopedic surgeon who's very interested in neuroarthropathy, Charcot care, surgery for Charcot. And when I first started my practice, I did a lot of Charcot surgery, and they all did terrible. So I stopped doing Charcot surgery, and then I did a lot of conservative management for Charcot. And then I started doing more surgery for Charcot and realized that I just was not doing it well enough after spending time with Mickey, talking to Mickey, reading Mickey's papers, and going to meetings with Mickey. I realized that some things I could do differently to try and improve the outcomes of my patients. And here's a quick funny story. The guy next to him is Bob Anderson. These guys are two like legends in foot and ankle surgery, and they were here in Toronto a couple years ago. We went to a baseball game, and we walked from basically here down to the Skydome, and Mickey and Bob talked about the best cross-dressing bars they've ever been to. So if you're going to think about salvage, you have to think, will it outperform in terms of function a prosthetic, right? What's the realistic endpoint? Because if you're going to tell a patient who's 78 years old that you need 6 months to a year to reconstruct your foot, and you have a 50-50 chance of still having an amputation, like you have to have a real conversation what that really means. And maybe that's not a conversation you should be having with that patient. Quality of life, it's really important, right? You see a 44-year-old guy who hasn't worked in 3 months, he's got Charcot neuroarthropathy, he's got to feed his family. If he has an amputation, maybe he's back at work with his prosthetic in 8 weeks, right? Versus my frame, my osteotomies, it's 3 to 6 months, right? And so those are real world things you have to talk about with patients. And you have to be honest about risks, right? This is risky, you are sick. These are big time operations in people who are unwell. And that's the kind of thing that we do. So you can see the bottom, you want to talk about neurotraumatic, neurovascular theories of Charcot, midfoot collapse, plantar ulceration, and so we do a midfoot osteotomy and a frame. Okay, so how are we going to select, how are we going to amputate people who are unsalvageable? So we finally got the meat of talk here, right? Clinical exam, those are the different kinds of amputations. People who are doing amputations in the room know about that, right? Again, you want to talk about the reasonable function and the proximal of the amputation, the optimal leg length, and you've got to ask the patient, what do you want to do with your leg? It's really important to know. Like this guy is not going to be happy with the signs, right? He's not going to be. He's going to be way happier with a Abalone amputation. Any amputation you do, it's about the wound healing because you don't want to reoperate on these patients. They're sick. They cannot afford to have multiple operations, okay? Biomechanics. We don't think enough about biomechanics, right? You take away a big toe, you're going to get the flexors engaging in the other toes, right? And you're probably going to end up with a hammer toe deformity. So maybe you should be correcting them all at the same time. Make sure you're thinking about the Achilles tendon. Make sure you're thinking about gastroc contracture. We know that if we take away, if we don't think about biomechanics and we take away, tendons that are important, the way the foot moves, you're going to have, metatarsal overload, you're going to have forefoot overload, your gait mechanics are going to change, and you're going to recur an ulceration. Those are levels of consideration. Just think about the anatomy, okay? If you're doing a shoulder part amputation, you're taking away tib band. Well, that means Achilles is stronger. So that means you're going to plantar flex your foot, and you're going to weight bear on the bottom plantar surface of that stuff. Again, here's Mickey. Mickey loves the Symes. I'm not a big fan, but he really thinks the Symes is the way to go. I find it hard for people to wear their prosthetics. And the soft tissue envelope on the bottom of the Symes tends to be a little bit fussy in terms of fitting into prosthetics. People like it because they can hop from the bedroom to the bathroom, right, without putting on their prosthetic. And in some congenital deformities, it's really useful. Abalone amputation. I think the biggest thing that I tell patients is Abalone amputation is not a failure. We think of that a lot, like Abalone amputation, this kind of amputation, because it requires so much energy to use Abalone prosthetic is a failure. In the right patient, Abalone amputation is a good operation. And sometimes, in circumstances where people are going to, have a quality of life affected by months and months and months of attempt to revascularize, at salvage, Abalone amputation may be a good operation. And a lot of Abalone amputation patients who do well, their wound heals, they don't have to have reoperation, they understand that prosthetic use is complicated and requires maintenance. They do well, they're happy. So, appropriate amputation of face unsalvageable limb is not a failure. Patient factors are very important, and what the patient wants is incredibly important, and where the patient is mentally in terms of being ready for their amputation is really important. Whatever you do, a salvage or an amputation, the wound must heal. So you have to ask yourself that. Can I get this wound healed with this particular procedure? It is not fair to the patient for them to go through it and not have the wound heal and be back to square one. And understand biomechanics. Thanks. There's a lot of